Hey everybody, this is Dr. Tiffany Lamberton of TMD Collective. I'm sorry about my voice. I'm in Chicago right now with the best study club, my Chicago study club. So I have a little bit of a sore throat from hanging out with all my dental friends, but I'm so glad that you have joined me here on the podcast. This next episode is one that you're not going to want to miss. I'm joined by a very special guest, Dr. Shereen Lim. Dr. Lim is a Perth-based dentist with postgraduate diploma in dental sleep medicine from the University of Western Australia. She brings a wealth of knowledge to our discussion. With over a year of experience in managing snoring and obstructive sleep apnea, especially in young kiddos, she's dedicated to promoting airway health from infancy, aiming to prevent these issues. Dr. Lim is also the author of the book Breathe, Sleep, Thrive. Discover how airway health can unlock your child's greater health, learning, and potential. If you haven't downloaded this book or listened to it, you have to listen to it or read it. In this episode of Jaw Talk, we'll explore Dr. Lim's favorite tools, her journey as an author, and her specialization in treating younger patients, among other intriguing topics. Ready to dive in? Let's go.
Quick legal disclaimer, all information in this podcast is the opinion of the speakers and not meant to be a substitute for a diagnosis and consultation of a qualified healthcare provider. Hi there, this is Dr. Tiffany from TMD Collective and Jaw Talk, and today I am so excited about my guest, Dr. Shereen Lim. Welcome to Jaw Talk. Thank you so much for being here. I just read your book, Breathe, Sleep, Thrive. It's a must read for anyone that is into airway dentistry and Maya. I had Dr. Jeff Rouse on the show just a couple weeks ago, and I saw wrote a testimonial for your book. I love that you really broke it down not just for practitioners, but also for parents that are looking at their children and some of those sleep things and want more information. So again, I'm just honored and excited. Thank you so much. You're tuning in from Australia.
Yeah, thanks for having me.
Yes. So tell us a little bit about your airway dentistry journey and how, you've just become a leader in this field. How did that happen and how did you become passionate about airway?
My first interest in airway was really because of my husband's snoring. That noise was really bothering me. So I decided I was going to learn more about oral appliances for adult snoring and obstructive sleep apnea and how I could help other spouses that were in the same frustrating boat as me. But once I became qualified in that area and started to treat adults with snoring and obstructive sleep apnea, I could see that for many people it was more than just a noise. It really was deteriorating their quality of life and their mood and energy, and people not being able to function well to their potential. And looking at these oral appliances, they're really suited for the non-obese people. It's a craniofacial problem we're trying to deal with. So we're giving people these dental devices when their jaws haven't grown properly. And I just wanted to know, how come we weren't developing the jaws when children were young? In dental school, we're taught, let's do early interceptive orthodontics around 7 to 8 years, but many times people are not getting that treatment. Orthodontists put children on watch and wait till age 12, straighten teeth with braces, sometimes needing to take out teeth. And I actually didn't want that for my children. I wanted to do early interceptive treatment, and that's how I got into the path of doing early interceptive orthodontics. And then around 2014, I met Dr. Christian Guilleminault, who was responsible for the initial research on palate expansion and obstructive sleep apnea. And I was saying, your research has really inspired me to learn more about early interceptive orthodontics. And he said, if you're doing this, you're too late. So I had no idea what he meant at that time. But going down the rabbit hole and learning more and more, I really understood that the jaws develop the most in the first 6 years of life. And the muscles, how they work during suck, swallowing, breathing, and chewing, they actually help to determine how the jaws are going to grow. So really, we have our best opportunity to get a better direction of jaw and airway development in those early years of life by correcting oral function. And so that's really how I got into it and became really more passionate about prevention rather than waiting for problems to occur. Obstructive sleep apnea is an end-stage problem. So why don't we get in and intervene and develop good nasal breathing and good airway structures early on in life to minimize those problems?
Absolutely. And then what did you do, like some training through like oral myofunctional therapy, or who were some of the kind of the big entities that were also impactful as far as kind of your postgraduate education?
Yeah, the first thing that I completed back in 2013 was a graduate diploma in dental sleep medicine. So I became one of Australia's first dentists to have a qualification in that side of things. And then when I wanted to learn more about orthodontics, I've done quite a few of the long courses in orthodontics, but one of the people that was influential was Dr. Derek Mahoney. So I'm not sure if you've heard of him, but he's from Australia and he trains a lot of general dentists in orthodontics. And he has really been quite pioneering in terms of how the jaws and breathing is related. So that was one of them, and just lots of different courses. In terms of myofunctional therapy, have done quite a few courses between me and the team. And one of our favorites is the AO with Joy Molar. Yeah.
Yes, that's the one I did my training through as well. In
Yeah.
about
It's fantastic.
2016. Yeah, a fantastic group. And I love that they do the coffee clatch sometimes
Yeah,
on Saturday
absolutely.
mornings. And, we were mentioning before we started recording Dr. Kevin Boyd, who I think is amazing. He's spoken on there and just always very great speakers coming in and bringing new information and new literature reviews. And I love that collaboration.
For sure. Yeah. I like you, the coffee clutch. It's not something that I can tune into in my time zone, but just having access to the recordings, having done the course like 10 years ago, I think the AOT, I definitely support it.
Absolutely. Absolutely. I love that you said in the book that in order to, kind of treat that younger and younger patient, you had to kind of also prepare your team for instead of, maybe like 7-year-olds, more like 3 to 4-year-olds. What did that look like when you started to change, kind of your style of practice?
What did that look like? Well, one of the big changes that's occurred in the last, I guess, 6, 7 years is having the digital scanning. So that's really been helpful. There's no way that I would have started treatment on children 3.5 and 4 without the digital scanning. Having to put the alternate impressions and having to manage that is really tricky. But digital scanning makes that quite easy. And then just being able to relate to patients really well. I think nobody in our practice really wanted to see children previously, but we've just been able to get down on their level. I think that's really important, just to be able to talk to them and tell them and show them and do things so that they can really feel comfortable with what's going on. And just engaging with children. I think one of the things that I've learned is just to talk to them, and if they don't respond first, to actually just keep talking and going down that path until they can open up. And I think very key in our practice is making sure I personally prefer children to go with a team and for them to work without the parents in the room. I think that it allows children, just controls the dynamic. We can actually get children more engaged, and the teams are really good at working with the children and getting everything they need done. And for me, it means that I can spend time with the parent and the parent can discuss all their child's concerns without the child having to listen to what their parents perceive is going not as good as they would like.
Right. Right. And then when you're seeing, let's say a new patient in the practice, maybe the child's 3 or 4 years old, the parent, you probably have some intake as far as just like sleep questionnaires. Is there a specific, is it bears or what are some of kind of the information that you're gathering from the parent about the child's sleep habits or, maybe oral habits? Is there thumb sucking? What do you like to use in your practice for gathering that, kind of initial comprehensive, interview?
Yeah, I have my own set of questions and checklist of what I'd like them to look at. And really, that's in the pre-treatment form, just for them to go through, because a lot of the time parents, they may think that their child's a really good sleeper just because they don't have to wake up to go to their child. So I've just got a bit of a list of things that they can start looking at. And some of the functional history questions are how the mouth has been working from birth, whether it be through breastfeeding, how they're chewing their foods and speech, and dummy use or pacifier use and any other habits. So I really want them to fill out their form and start thinking about those things. But when the parent comes through in the room, I will go through that again in more detail, because I think that that's where we get a lot more information as well. So I don't use a standard screening questionnaire. It's mainly interview and allowing parents to really talk and to hear more about what's going on for them.
And then what type of like sleep screening, like are you like recommending, like a home sleep test or like an in-lab polysomnograph? What types of things do you typically do for that really young child?
Yeah, to be honest, I don't really send for sleep studies as such. Well,
Mm-hmm.
I think a lot of the time when we send for sleep studies, those are really looking for obstructive sleep apnea, and they're really only diagnosing there's a criteria a child needs to stop breathing for a certain amount of time, and a lot of the time when they get that report back, it will say your child has no sleep apnea, and therefore it's not very motivating for a parent to proceed with treatment, even though they know that their child has a lot of disturbed sleep and symptoms. I think for children, what we really need to pay attention is to have nasal breathing day and night. And mouth breathing is considered open mouth breathing for 10% of the night or more. So I don't think a lot of the sleep studies and tests really are that sensitive in relation to that. If a parent has concerns with disturbed sleep and teeth grinding, snoring, I think those are the concerns that we really need to be addressing. So I do take in what the parents say about those symptoms, and that's how I will review it. I think that's what's really important to parents to know that those symptoms are reducing. So I don't typically have that. I think a lot of parents, I listen to what they say.
Yeah, yeah. Well, as a parent going through a sleep study with both of my kiddos on two separate occasions, because my brother-in-law is a sleep physician. And so I was like, okay, we're going to do the in-lab one. And it's just terrible, like you don't sleep well, your kiddo
Mm-hmm.
doesn't sleep well. I think, like you said, some of the sensitivity of the hypopnea is really good information. But, like you said, it may not be the whole picture.
Mm-hmm.
Yeah. Super interesting. And so, kind of going through this journey as a parent too, did you feel like you also had kind of like a different perspective as you're watching your own children kind of grow and develop through their process?
Oh,
I feel
my
like I
poor
did.
kids. I think my poor kids are they say they don't know what they want to be when they grow older, but they're definitely not going to be dentists
Not
and
a
do anything
dentist.
moving, because I think they've had a lot of me looking in their mouth and, hey, do you mind looking, showing me, and trying all different sorts of things on them. But yeah, I think having children, I knew that I didn't want them to go through that traditional orthodontic approach and having all their teeth out. So yes, that was one part of what really motivated me to learn more. And I had one child that's older, and she probably missed out a little bit more. I wasn't on top of things as much. So it really makes it clear that when we can intervene early, we're going to get better outcomes.
Absolutely. Well, and I think when you're talking about intervention, it can be even just the smallest things, like maybe, recognizing allergies or, not having the pet in the room or, in our country, like looking at tonsils and adenoids and, deciding, do we want to do palatal expansion versus, taking the tonsils and adenoids out. I know you're a big proponent of palatal expansion. Tell me a little bit about your process of thinking that versus, maybe a surgical procedure.
Yeah, I think no parent ever really wants to put their child through a procedure. And the problem with the surgical procedure is that I see a lot of children that have it. And yes, it helps them in the short term. They can stop snoring, but many children have persistent mouth breathing and teeth grinding. And then if we wait a little while, we're going to have more and more of those symptoms recurring. So it's not really a complete or long-term resolution. In my perspective, I do think that the enlargement of the adenoids and tonsils are a symptom. And so sometimes it's really important that we remove those so that we can clear the airway and get children breathing and sleeping better, particularly when they're really young and there's a lot of brain development going, because we know those risks of airway obstructions. However, I subscribe to the hypothesis by Dr. Howard Stupak. He's actually published a hypothesis where he proposes that the origin or the root cause is a narrowing of the palate. So when we have a narrowed palate, and it may not be the most narrow, it's some sort of subclinical deficiency, it's linked to a narrower nasal floor. And when we have that, we're going to have increased resistance to nasal breathing. And so when we have to breathe harder through our nose to pass air, it's like sucking on a straw quite hard. We're going to get collapse of the airway. And so when we get these collapses of the airway, what happens is we get the pulling of the tissues within the airway, and that can contribute to the swelling. And that, if we can understand that, what we can understand is that if we can, when we take the adenoids and tonsils, we're not going to get the complete cure. There's an underlying problem, and it's to do with the way that air flows and poor nasal breathing. And so if we widen the palate, the research by Dr. Bocker, who I heard your interview the other day, and Dr. Audrey Yoon, is that children that have palate expansion, they may actually have reduced volume of the adenoids and tonsils within 6 weeks. Mm-hmm. And this is correlated to an improvement in their sleep symptoms. And if we can do that within that 6-week period, we can reassess to see, does a child need to have their adenoids and tonsils out? Because if there's improvement, we may be able to continue down this path. And I do think that gets closer to the root of the problem. But we don't want to wait forever. I think there's always a role for surgery. We need to get children breathing well, and it's a multifactorial problem. So oftentimes it will need multiple treatments.
Mm-hmm. What are some of the norms that you're looking at with like the primary first molar? Because I remember, I heard it was like if you can stick a cotton roll kind of between that to like that sort of like adequate like maxillary arch width. Are you like what types of kind of norms are you looking at in your practice as far as intervening?
Yeah, well, when I look in a child's mouth, I get a photo of them biting their teeth together with the retractor, the frontal occlusal shot, and we're looking to see are their lower teeth tipped in,
Like
and then I try to imagine how wide do I want that palate to be if those teeth were upright. Mm-hmm. So I use that as a gauge when I'm doing expansion as to when to stop. Mm-hmm. If they have a retrognathic mandible, I'm also doing an as-if position. So I try to get the child to go edge to edge, because then we'll see a lot of the time the jaw is actually narrow, the palate is actually narrow. So I'm also trying to imagine what would it look like if that front jaw was forward? How wide would I need that palate to be posteriorly? And then I'm also looking at the lingual palate suction, or what would happen if their tongue suction? Is there a lot of spillage, or is that tongue pretty well contained in that mouth? Because if there's a lot of spillage, then that's another factor that I'll need to widen their palate more. So I think it is variable for each individual more than any exact measurement. I will look at their individual mouth.
Yeah. Well, and one of the things I think what's wonderful too as a general dentist is that we now start to have modern imaging at our disposal as well, with cone beam CT and sometimes, MRI imaging, that we can really get more information about kind of that bigger lens of not just how the teeth fit together, but like you said, what's happening with the maxilla, what's happening with the mandible, how is it growing? And so important. I realize, with me and kind of like TMJ, a lot of times I'm getting patients that have already gone through kind of traditional ortho, and then they've developed, TMJ symptoms or maybe clicking and popping. And I'm always an advocate of, we've got to get to that younger and younger intervention before, and like starting to recognize when those problems are going to be starting to develop. Mm-hmm. And so I think, I'm looking at, maybe a lot of my patient population is like 35. And then, now I'm starting to get some 12-year-olds, but now I think I need to go younger. Mm-hmm. Yeah. So talk to me a little bit about, do you utilize a lot of imaging in your practice as part of your treatment plan, or do you utilize cone beam CT? How does that fit into your practice?
Yeah, I think the cone beam CT is obviously very useful, especially we know some of them, their radiation exposure is very equivalent to a regular OPG X-ray film, and you get so much more information. However, in our practice, we don't have that facility. And in fact, the closest one is around 30-minute drive from where we are. So it's not standard here that every practice has that. So I generally take an OPG, and I think for the purposes of what I'm doing, it's quite sufficient. But I do think there are certain people that it would be so valuable, like a lot of the children that have enlarged adenoids and tonsils, and the ENT is not really confident in scoping and finding out how big they are. Mm-hmm. Yes, I think there's a really great role for that. And also for research purposes, people wanting to be able to follow up and just see what is the actual impact of their intervention. Yeah, I think there's an important role, but for my everyday practice, I don't really need it. It's not going to change my treatment plan a lot. And at the end of the day, the patient's symptoms is really going to be what is quite impactful for parents.
Yeah, absolutely. Now, I feel like there can sometimes be some controversy within the orthodontic field about expansion and early interceptive. Some say, well, they're just going to relapse anyway. Could you speak to that?
Yeah, for sure. It's very controversial, especially where I'm from. There's a lot of resistance from the orthodontic department.
Mhm.
And what I find so fascinating is that some of the very early influential work on children's palate expansion was actually done right here in Perth. So, for instance, in the ENT journals, there's a research on 310 consecutive cases of palate expansion. They did children as young as 4, no crossbite. They just wanted to manage it for problems with nasal breathing, things like asthma, septal deformity, recurrent ear infections. And they did this and they were able to show that many children converted to nasal breathing. And what they actually ended up doing was treating about 2,000 kids in the 70s just for medical referrals and to address their nasal breathing. And it was done here, yet it's not really taken off. It sort of died off when the ENT passed away. But I recently met with the orthodontist, and he's around age 90. And even he is saying the earlier you can do it, the more stable the result. It allows the muscle function to return, and that can help redirect growth. And I think when we talk about instability of the orthodontic treatment, what we're failing to recognize is that the muscles, how they're working, is influencing that growth. And if we don't address that through myofunctional therapy and restoring nasal breathing and getting good tongue function, we are not going to have stable results. So if we're doing early interceptive treatment, we really should be pairing that up with restoring the muscle function and nasal breathing. And the earlier, the better, because once we correct that structure and make more room for the nasal passages and easier nasal breathing, and once we make more tongue space, it's going to be easier for correct function to be restored. And we've got to break that cycle of poor function and poor structure by intervening with that structural correction early to help get that better function.
Yeah, absolutely. I totally agree with you. And I firmly believe that every general dentist and orthodontist should have a myofunctional therapist, either working right there in their office or one, right down the street that they can refer to. I think it's so important. And we have some amazing people, here in Washington State that I've had the privilege to meet with. And I think that is such an essential part of your team. I'm curious, have you trained some of the people that are part of your team? Are they also OMTs, or do you typically refer out for that?
Yeah, I have a team member that's done quite a bit of training, and also, yeah, I have trained some of my team to be able to look at those things and help children and guide them along as well under my supervision.
Yeah, I think that's wonderful. And I think that general dentists all need to have an OMT right there in their back pocket to be able to
Yeah,
work.
I'm not sure if you read the recent article by Nicole Goldfarb from San Diego. She published like an 8-page article in Dental Sleep magazine, and it's why every dental office needs to have an OMT. So a really comprehensive article, and there's a set of questions that you can answer and get some CE points as well. So it's great to see this information being so well out there for other people to read and become inspired to learn more.
Yeah, yeah. Well, I haven't seen that, but I will look for that for sure because I'm a huge advocate of that as well. So what would you say, we were talking a little bit about palatal expansion. What's kind of like your workhorse? Do you use like a Hyrax, or do you like, what type of expanders do you like typically? Because everybody's a little bit different and, kind of in their hands. What are some of your favorite?
Yeah. Over the years, I've tried nearly every expander. I've tried so many different expansions, but my favorite that I really come to and now exclusively use is the removable BioBlock expander. So it is a removable device, and in addition to the expansion of the trans dimension. It's actually got some cap wires at the front of the appliance. So when I remove it to do adjustments, I can actually move those wires. And so as we're expanding, we can actually get some really good control of the anterior arch. So we can really change a V shape into a U shape. If they're sort of class underbite, we can actually get that out, the front teeth out into the right direction. If there's any minor rotations or crooked teeth, we can actually kind of align the teeth as we're expanding. So I love the fact that it can do so many things at the same time. It really gives a nice facial appearance. But the main downside of that is the compliance, because the biggest problem would be children that have a tongue thrust. They don't know where their tongue is going to go. They're more prone to flicking the plate out,
flipping it
biting
out of
it in
the
and out, distorting the class, making emergencies and dragging out the treatment. So it has to be pretty good case selection. And many times I'm going to train children to put their tongue in the correct spot before we even begin. So they're going to have less chance of habits and emergence.
Yeah. No, one of the dentists that's in my study club, Dr. Courtney Donko, is doing those as well. And I love her videos. I don't know if you look at those. I'm like, they're so beautifully done. And, she's great at like explaining like how she wants them to seat and just helping like work with the families on compliance. So I love that.
And what she's done, it looks beautiful. Yeah.
So what are some of the things, let's say that you've gone and worked with the patient, they've done some, work in the transverse plane, but you're still seeing really that deficiency with that really retrognathic mandible. Let's say that, it's really compressing kind of the oropharyngeal airway space. What are you thinking at that point? If you've kind of like hit that wall of, you've done some of the transverse work, you've done some of the myo work, now what?
Yeah. This is where I think it's really important to start treatment early. Mm-hmm. Because if we have a retrognathic mandible, a lot of the time it means there's a narrowing of the palate. Mm-hmm. And we have that mandible is actually trapped. Very much like if we have a pointy shoe or a narrowed upper arch, that foot can't slide in all the way, or that lower jaw gets stuck. So I think if we get in early enough, what we need to do is we need to open up or address the palate. And once we've addressed the palate, we need to get good tongue to palate suction. And when we get good tongue to palate suction, we should find that the lower jaw will come forward. Mm-hmm. So I think that, myofunctional therapy, I like the use of habit correctors, like for instance, Healthy Start or MyoBrace type of appliances, because they help posture the lower jaw forward and retrain all the good muscle patterns that we want to see. But the other thing that I'm looking at a lot more closely is posterior tongue tie. Because I do think that if we have a posterior tongue tie, that can hold the lower jaw forward. So if we have an anterior tongue tie, that may be more related to class 3, in my opinion. But if we have the retrognathic mandible, that might be more posterior tongue tie. Especially listening to, adults or some of the older children, having that tongue tie release, they feel that they can posture their lower jaw forward more easily. So I do think that the earlier we can actually do these treatments and optimize the upper jaw, and then get the postural retraining, addressing the tongue tie, the more easily that lower jaw is going to come into place. Mm-hmm. I think it's harder when we have an older person to get that occurring, like a non-growing person. You would have to look at other options to get the same sort of result.
Right. Well, and then I think we start to see all these different muscular compensations of, that we have to kind of like unwind, like the forward head posture, or, maybe like some of the neck muscles. And that's where I really think that pulling in kind of that comprehensive image, modern imaging can give us so much, information 3-dimensionally about, what's going on with the upper cervical and what's going on with some of those systems. MRI can tell us a lot of information about the soft tissue, cone beam CT about the hard tissue or the skeleton and how that's growing and changing. Yeah. But I can tell you here that, there's still a lot of pushback, from different, even pediatric dentists about, wanting to do more imaging or like, why would you do that? But to me, those are data points and, you can really track over time what's happening. And I think with the TMJ, not every patient is going to have a healthy jaw joint and grow like we expect it to, right? So maybe also, recognizing who that patient is that's going to maybe have some difficulty later on down the line. That's what I feel so passionate about. Like you said, kind of that early intervention and looking at that bigger lens of being able to look at both airway, myo, and the jaw joints too. I think the jaw joints are, just kind of get left out of the picture sometimes. So I'm like, don't forget about the joints.
Yeah, well, I really like Mike Mew, his paper, Craniofacial Dystrophy, where he really outlines that when we have crooked teeth, it's actually a symptom of a bigger problem, which is a distortion in the way our facial bones are growing, because our jaws are really only a small part of this whole system. And so when we have those crooked teeth and the poor jaw development, that's actually an airway problem. And that's actually our TMD problems. So all these problems,
All
our
related.
neurosinuses, they all have the same origin. So we need to address the jaws and make sure they're growing well.
Yeah. Yeah. Absolutely. And, one of the books that I just bought that I am like such a big proponent of is like the specialty imaging with Dr. Tamini. So I had her on the show and, she's so amazing in the OMFR world, because it's like, I want all that information in my brain.
Yeah.
But I think that that's such the oral maxillofacial radiologists are part of our team, right? Just so you have the oral surgeon and you have the, orthodontist, that the dentist or the orthodontist, and you have the OMR, and you have all of these people kind of working together so that we can really guide growth in an optimal way for sure. So tell me a little bit about being an author. How did Breathe, Sleep, Thrive, which we're going to include the link to your book in our show notes. And I just read it. I'd had it on my list to read for a long time. And then I was like, okay, I got to read it. It's so well written. How did that come about? Or how did you decide I'm going to write a book?
Yeah, the original prompt was 6-7 years ago, when I decided that I was going to offer more orthodontic treatment. And how do we tell parents? We've always referred to an orthodontist. We've taken out their older children's teeth at their request. How do we try to tell them, oh, you know what, we might do things a little bit differently, and here's why? It's not really a straightforward conversation. We've got to connect a lot of dots. And so that's why I really wanted to write the book, to be able to discuss why we need a different approach to orthodontic treatment. And then as I learned more and more what we could do for younger and younger people, and how the oral dysfunction impacts the jaw development, really be able to connect those dots for parents as well, because there are so many things that in childhood gets dismissed as normal things that children will outgrow, whether it be the breastfeeding problems or the reflux-like problems from sucking and swallowing of air, or bedwetting, teeth grinding, all these things that parents think are pretty normal. I really wanted to help highlight that they could all be connected to poor airway health or poor breathing and jaw development. And so that's how the whole process came about. And it did take some time, because I had a lot of coaching, but a lot of it was becoming out too technical and too textbooky at the start, but it really needed to be a parent book. And I think that was a really useful goal, because now that it's useful for parents, other practitioners are actually recommending it, for their patients. And
well, I think
now
it brings those two audiences together very well.
For sure. And before it was actually trying to help educate parents so that they understood what I was doing. But now we're so busy, we're so busy, it's really hard to take on new patients. But to then be able to help people that were in my boat, I find that really satisfying, to help other practitioners to help their patients as well.
What advice would you have, like a general dentist that wants to kind of bring in this model or style of practice, kind of build what you've built? How should they start?
It's really important to learn from lots of different courses. Really, there's sleep and there's tongue tie and orthodontics. There's so many, and myofunctional therapy. There's so many things to learn. And I think that we can get the biggest picture if we learn from lots of different fields and do things like the AAPMD, AAMS, they're really great organizations because they bring together lots of different professionals from different fields. And so that's really where I've really been able to expand my world and knowledge, just learning from different people, whether it be the physical therapist or the lactation consultant, to really get a good understanding of things. And I do think that there are people that have done numerous courses that have written to me about the book and just said, you know what, I've done a lot of courses and it's really connected everything together. So I do also think that Breathe, Sleep and Thrive is a good starting point just to tie in those dots. But yes, I think learning the most that you can. There's so many podcasts and free webinars and things like that these days that it's quite easy without having to travel as much as I had to back in the day.
Right, right. I don't know how you did it, like being a mom and a practice owner and an author. Like, did you feel like you were going in a lot of different directions? Oh, I think it's fantastic. And like I said, I recommend your book highly. And like I said, we'll put the link in the show notes if people want to check that out. Tell us like what's coming up for you that you're excited about. Are you going to be speaking, giving any lectures? What's happening for you that you'd like to tell us about?
Well, I am planning to do some sort of airway conference in Australia next year. So I haven't really finalized the details for that, but it's been a while since I've organized an event. And I think there are so many people that are wanting to hear more. So that's going to be on the cards. But in terms of the next speaking event, it's the Airway Palooza by Airway Health Solutions. I'll be coming to the US for that in next March. So really looking forward to it. They've got I think there's about 12, 13, 14 people all doing talks about an hour each. So I think that will be a really great, fun networking event. And the thing that I'm really looking forward to really soon is going to Rio for the World Sleep Congress, which is done every 2 years. And this year in particular, Dr. Audrey Yoon, she's launching a World Dentofacial Sleep Society. So she's got all the different sleep societies from around the world all uniting to form one international dental sleep society, and they're going to do more focus on early intervention as well, so helping children, because a lot of the dental sleep medicine societies, they do focus mainly on adults. And so for the first time, I think it'll be great to get more attention into this area. So I'm looking forward to that. That's going to be a lot of fun.
That's great. I know she's a rock star in the profession, just like you are too. And I love following both of your journeys, and just the way that you keep coming out with new research and new information. I think it's just essential what you're doing. So thank you.
Yeah, no, thanks for what you're doing as well, Tiffany. I really look forward to following more of your episodes, and I do think the TMD connection is something that I need to learn more about. So I appreciate you bringing more information in
Oh,
that area
thank
too.
you. Well, like I said, the PT part of me like wants to pull in like all the muscles and the fascia and like the cervical
Yeah,
spine, and
absolutely.
can not leave that out of the picture too, because even when we're looking at CBCT, we can see something as just like, okay, this is a snapshot in time. We can maybe see these different things, but how is the patient functioning? How are they moving? Like, is there restriction in the spinal movement, and is there asymmetry in the muscular development? And so I think kind of pulling in kind of that PT piece of it is where I get really excited about as well.
Yeah,
So
absolutely. So much to learn.
yes, yes. Well, thank you so much for being on with me today. It's such an honor to have you, and I'm so excited. And like I said, we'll link everything in the show notes with how people can find you. And like I said, your fantastic book. Everyone needs to go out and buy that right now.
Thanks, Tiffany.
So,
Thanks for joining us today on this episode of Jaw Talk. If you're interested in learning more about Dr. Lim's work or her book, Breathe, Sleep, Thrive, be sure to check out the show notes for links and additional resources. Don't forget to subscribe to Jaw Talk to stay updated on future episodes. And if you enjoyed today's conversation, please leave us a 5-star review. Your feedback means the world to us. Until then, remember to prioritize airway health, keep learning, and stay curious. Thanks a lot for listening.